Great. So I'll just flick on to where you are. You were on this slide. Okay. Over to you,
Next
Colin.
slide. Okay, so yes, our vision really statement for the eHealth program in RCSI is keeping people with epilepsy independent. Next button. And that really brings in the quadruple aim that the HSE digital transformation, better outcomes, lower costs, improved clinician and patient experience. And I'll tick each of those as we go through. Next.
Bear with me. There we go.
Okay, so the ethos of the department has been in the last number of years. I would admit not since the beginning, but certainly in the last 5 to 7 years, really a patient-driven design component. This is one of our heroes, Sarah Regare. She's a young woman with Parkinson's disease that she developed, and she was also a researcher and applied to do a PhD at the Karolinska Institute. This series of dots here, 8,765 hours in a year. These are the number of hours in a year. The little red dot is the amount of time she's under the care of a neurologist. Goes to see him once a year for a follow-up. The rest of the time, it's up to her. So this is self-management 101. She manages her condition all year round and goes in for advice once a year. And when she wanted to study what it meant to do that, the research panel said, but Sarah, why do patients want to do research on themselves anyway? Isn't it better that you just give your data to a proper researcher? So this has really been an enabling statement for our service. And we constantly go back and forth with a group of patients to help us design not only the services we want, but also the research projects. Next. So the journey from the start of this, going back to the digital desert of the early 2000s in Irish healthcare, this started off as a health research board research and development project. Mary Fitzsimons, myself, Norman Delante, a few other clinicians sat down to decide what we wanted to do. There's at the top left is a picture of a typical chart of a patient with chronic diseases, and you'll still see those charts in hospitals today. And so the idea was to change that and turn it into a digital record. And that journey, I would always argue with Mary that this is not squiggly enough, this line, but it brought us up to a position where we have about 10,000 records. Now, about a quarter of the patient population with epilepsy are now have their records digital. And it's used all over the country in epilepsy centres. Next slide. And it's got, this is just of the opening screen. It's got 400 data tables, 3,000 data fields, and currently 10,000 records. So we have conservatively 50,000 patient years of data. And I can tell you that this is the single biggest repository of patient-related information about epilepsy in any single population. And just show you a couple of the screenshots we have. Next. So this is our summary record. So once we populate the whole record, we have a summary slide, and this we can give to patients or GPs or other specialists. And you can see all the tabs down the left-hand side, which are arranged in a sort of fairly traditional, epilepsy history, social history, allergies, medications, examination, etc. Next. This is an example of the tool we use to record the seizures. What's important about this is you can see there's a lot of tick boxes and drop-down menus, but there's also a lot of natural language. And we haven't even touched on the capability and the possibilities for AI around natural language processing over these 50,000 patient years. So we've got a lot of language that's generated by clinicians describing seizures. Next. This is just a typical example of our medication module. So we give doses, start dates, end dates, side effect profiles, descriptions of responsiveness and blood levels. Next. So really what we've been doing with this record over the last decade and a half, as you say, we've populated with 10,000 individuals. We have 50,000 patient years. It's used across 10 sites in Ireland, and it supports about 700 discrete clinical encounters per month. What's important about this is this isn't a registry. It's not a research, primarily a research tool, although we do research from it. This is an active point of care tool. So simply put, if we didn't have this record now in my service here in James's Hospital, we'd have to close down because we just cannot do our clinical work without it. and we're completely paperless across several aspects of our clinical care. So we use it for telephone advice. We use it to collaborate across geographical centres. That's not a small ask. I mean, given when I explain this capability to our friends in the United States, they don't understand what we're talking about. They're so much in competition with each other that they can't believe that we cooperate across geographical and institutional boundaries. Next. So just hit the next button. So what I'm talking about, no, go back. So what I'm talking about today really is back one, please. What I'm talking about today really is one real pathway, which is the pathway from community to the outpatient ambulatory epilepsy centre through the general practitioner. We have capabilities around digital care as inpatients and also through the emergency department, but I'm not going to talk specifically about those today. But just to say that we have digitized every aspect of patient care between community, hospital care and home. Next. So one of the key areas that people have brought up today, we talked about telehealth and virtual care. And for us, this has been a growing project way before COVID started. And that's an important point in relation to the data I'm going to show. For us, it was always about patient preference, about value, and about reform of health system. And so way before COVID started, we were investigating the possibility of delivering virtual care. And if you just hit the slide. So this is a much representation of the journey we've taken from the left, which is the typical overcrowded outpatient department, the large, indecipherable patient chart, through this maze to the point where that's me doing a video call with a patient, using their point of care EPR record, and the patient there at home using an e-portal where they can look at the same record. And this journey has been an amazing one, and one that existed well before COVID came. Next. So this is an example of how we started moving towards virtual care. This is a data tree, which is created from the Microsoft Business Intelligence software. And what you can see here is that the green square represents our face-to-face care, about 700 visits face-to-face in 2015. The black is what we did, what was our virtual care service, and this was typically unscheduled telephone advice. And you can see they sort of vied for each other for dominance in terms of the data. Next. By 2018, you can see how we're starting to squeeze face-to-face visits with the use of virtual care. And specifically after 2018, we began to work with what we call scheduled virtual care. So most virtual care up to that point was, again, unscheduled telephone calls from patients asking advice about side effects, doses, etc. But then we started to move towards virtual scheduled care. And in December 2019, we had an active program of cutting out one whole clinic per month of our chronic disease management group in James's and doing it purely virtually. And next slide. So then this happened. This is the BBC announcement of the pandemic restrictions occurring in Ireland between the 12th and 16th of March. Next slide. And what I'm going to show you now is data across two large epilepsy centres using the EPR, again, the Microsoft BI Business Intelligence data trees. So you can see again, the green is between Beaumont and James's. Between December and March of 2020, we had 695 face-to-face visits. And again, our telephone encounters were 400. Next slide. So as soon as the pandemic hit between April and June, you can see how the face-to-face encounters, the little green square is completely squeezed into the corner. And the red or orange color is all our virtual care. So we literally switched overnight to complete virtual care. I can safely tell you now that we didn't accrue one patient waiting extra time during the pandemic. There was absolutely no growth in the waiting list across either of these two large centres in relation to epilepsy care. Next slide. So the one question was, okay, it's all easy to say that you switched into virtual care, but really, was it appropriate? Did both the patients and the staff appreciate it? And these graphs very simply show The blue are the reactions of staff and patients before, for the virtual care process before the pandemic, and the grey is after the pandemic. And what you can see is that pre-COVID, somewhere in the region of 80 to 90% of patients thought that, clinicians thought the patient was suitable for virtual appointment. And then after the pandemic, they didn't change at all. Similarly, vast majority of staff felt that patients were basically, they would be happy for their patients to continue with virtual care. And on the right-hand slide of the slide, you can see these are the reactions of the patients. So if you count the patients, how was your overall experience of an appointment over the telephone? Between excellent and good, there's basically no difference pre and post-pandemic. So the important point here is pre-pandemic, we spent a lot of time trying to decide to stratify patients, thinking, is this patient suitable for virtual care? As soon as the pandemic hit, everybody went into virtual care. And what we found was that it didn't matter. We didn't have to really streamline and stratify patients. They universally accepted it, and it was generally very well accepted, and both staff and patients liked it. Next. One other important point, I mentioned the portal earlier on. So this is, again, a research and development project called Pisces, which has evolved into another HRB-funded project called the APA project. And this was the development of an e-portal to improve trust, transparency, and inclusivity of patients, really engaging with patients as members of the healthcare team, going back to that ethos of patient-driven design. So the patients really became safety partners, and we have a lot of data now on patients' progress and reports, which we've published. We've had one paper already published and another is coming out this month. Next slide. And this is what the opening page for the patients looks like. And again, very importantly, this is the end result of a patient co-design, a series of workshops where our patients came and helped us design what this should look like. So the patients can look at their epilepsy summary, they can read their letters from their visit as part of the open notes movement. They can answer questionnaires and help us measure their progress. They can declare goals for their epilepsy, etc. Next slide. Next slide. So there were 73 epilepsy users and 20 clinicians who used the portal. And these are just some of the comments made by patients as part of our ethnographic study. It's very empowering to be able to read your own healthcare record. It's really a fantastic way for patients to feel more in control of their healthcare. One more. And it gives me a sense of ownership over my medical files. So again, this is really the apotheosis of our ethos of patient-driven design, transparency. Next slide. So final piece of digital care really was our outreach service. So this is just one of several outreach services we have around the country. This is Lorraine O'Halloran. Lorraine is the only Olympian whose signature I have. So Lorraine won a gold, silver, and a ribbon at the Athens Special Olympics in 2012, and she works part-time in the canteen in Dr. Stewart's Hospital. So in March 2017, myself and 3 other clinicians went over to Dr. Stewart's Hospital, and over 2 days we met 400 patients, including their families, patients, carers, and we uploaded all this information into the EPR. And ever since then, we've managed pretty much most of their issues using the point of care EPR. Next slide. And this is the data from that. So after the outreach clinic, in the 3 years, we measured the outcomes 3 years before and 3 years after the start of this program. So we have 3 times less outpatient visits, 3 times more telephone encounters, and we have 3 times less visits to the A&E. And I think this is really quite startling outcomes from the program. Next. So there's a big, obviously, data analytic capability with 50,000 patient years. And this slide I like because it indicates the sort of learning health system that we've developed. So just hit the slide a couple of times and those pictures will come up. So what you see here is on operational analytics, we have medication safety reporting. On the research side, we've got heat maps of etiologies of epilepsy, and we've got cross-referencing various etiologies to each other. And on the personal analytics side, we've got patient-reported measures from the EPR, and then we've got the COVID service delivery reporting. So this is a constant cycle of learning. and every time we have data, we put it in. Next slide. This is purposefully a slide that you can't read, because these are 23 research questions, which rose from one data analytics reveal that was done by our data analytics person, Derek Corrigan. So as he was talking and showing us slides of data, myself and Norman Delante, experienced clinicians for 20 years, started writing down important research topics that were arising from the data. Each of these questions could support 2 PhDs. So that's 46 PhDs from one data reveal of 50,000 patient years. Next slide. This brings up the classic Donald Rumsfeld, the known knowns, the known unknowns, and the unknown unknowns. And that last one was the most amazing thing that came out of our data analytics drive. Next. One thing we talked about, whether all of the slides should talk about ethics and governance, and it's interesting that that hasn't really been discussed too much in today's talks. I'm sure there's going to be future DAFs on that. But this is a big part of our program. We have a postdoc, Tim Jacquemart, who's an applied ethicist, and he's published this data recently in BMC Medical Ethics. Risk, benefits, privacy, autonomy, responsibility, and human relationships are all part of this. And it's a very key part of our e-health drive, is to understand the information governance and ethics of everything we do. Next slide. So to finish, does the Digital Epilepsy Care Service cohere with the HSE digital transformation agenda? And people have mentioned the stay left, shift left analysis. But what you can see is, next, we have definitely delivered on lower costs right across the examples I've shown you. We've delivered better outcomes, improved patient and clinician experience. And I think we are hitting all of those buttons on the quadruple aim. Next slide. So I'd just like to thank particularly all the people living with epilepsy and their families and carers, but these are the various people who've all been involved over the years with this. I will say finally, you know, despite what we've achieved here, and I haven't really talked about the future, I think I'm letting the data speak for itself. This has been a very, very tough journey, and it's fantastic to be part of the Living Lab, because to be honest, this has not been a journey of pushing open doors. And Martin Curley will know, and the reason he's set up these living labs and he's driving this, because this hasn't been the ethos of our health system to encourage us. We've been, you know, I can remember sitting on the tarmac at him in Heathrow Airport, putting an urgent phone call into Tony O'Brien to try and keep our EPR funded one more time. We hit a funding cliffs every year for about 10 years. So I think when I look at all this data put together, you know, it's great to see it all, but I can tell you there was blood, sweat and tears put into it, and it wasn't, and none of it was technical. This was not, the challenges here are not technical. The challenges were always about the process and the people and the support. Thank you.
Great, Colin. Thank you very much. That was really, really compelling and amazing to see actually the amount of research that could be taken from just one analytic slice of the data. So this is actually a very mature living lab, and I think we look forward to actually seeing how this can be extended, potentially re-architected, but being used by actually all epilepsy patients nationwide. So thank you and congratulations.